You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for October 18th, 2024. This week, listener feedback on the c-statistic, atherosclerotic plaque imaging, WATCHMAN implant decisions in the United States, and Deprescribing. First, a few notes before I start. I am in the most amazing city of Vancouver, Canada. I'm here actually for 2 lectures. Thanks first to the University of British Columbia Cardiology Group, especially Jason Andrade for the invitation to give cardiology rounds. I also want to thank the Therapeutics Initiative Group here in BC for the invite to give a critical appraisal on heart failure drugs. One of the highlights of these trips is speaking with the cardiology fellows. I like to tell them that the 3 most common procedures that I do today in the EP lab, AF ablation, cardiac resynchronization therapy, and conduction system pacing, were not even thought of when I was trained in EP. It's crazy how fast things change in medicine. So I say to the young people, buckle up. I want to make a second note. I received an email this week. I've been trying to give first authors credit when I mention the study. Sometimes I mispronounce your name. I am sorry. I will try to reach out when there's a question, but often there is not time as papers come out a day or 2 before I record the podcast. I'll try to do better with pronunciation. Okay, let's go to listener feedback on the confusing c-statistic. I reported last week on a paper from the ProFid team wherein they looked at 20 cohorts trying to see whether use of left ventricular ejection fraction and also a broad spectrum of other predictors allows identification of low-risk patients who have a severely reduced EF that don't need a defibrillator, or a high-risk group of patients with mildly reduced or preserved LVEF as candidates for targeted defibrillator implantation. Their analysis pooled 20 data sets in 140,000 post-MI patients. The data sets came from observational cohorts, such as the Swedish Heart Registry, and it also came from RCTs like MADE-2 or SCUD-HEFT. Basically, they found little discrimination within the 3 groups of patients that they had. And the 3 groups were ICD patients with an EF less than 35%, non-ICD patients with an EF less than 35%, and non-ICD patients with an EF greater than 35%. And I want to highlight here the word within these groups, and that was a misunderstanding I had when I reported on the study. A registrar from the UK sent me a note about misuse of the c-statistic and how it may not be ideal in assessing models that predict future risk or try to stratify individuals into risk categories. He sent me to a nice review paper by Dr. Nancy Cook in Circulation in 2007. I'll link to this paper. I learned a lot from it. I have way more to learn about discrimination versus calibration, but the gist of the email was to know that the c-statistic is actually a pretty poor measure for risk prediction models when the risk is widely distributed across the population rather than a clear distinguishing cutoff between disease and no disease, such as you see in diagnostic tests. Accurate calibration of a model seems to be much more useful to classify patients into lower, higher risk groups, which might impact decision-making. And although sudden death rates were low, they were indeed 4 times higher in the EF less than 35% versus the EF greater than 35% group in the European Heart Journal paper that I reported on. And of course, this gradient of risk does suggest that the ejection fraction has utility in classifying risk. I emailed the authors of the paper, and they confirmed that indeed the primary question they had was a within-group search for low-risk patients in the low EF group and high-risk patients in the normalish EF group. And they did not find any. That's why the low c-statistic. Senior author Nicholas Dagras, and again I may have mispronounced that, who wrote that they also looked between groups. He wrote, quote, "What was not part of the primary analysis was the predicted performance of EF across the whole range of EF. Indeed, the endpoint rates in patients with reduced EF were higher than in patients with preserved EF, which means that patients with reduced EF had in general a higher risk than patients with preserved EF, which I would just add is what we expect." And Dagras goes back and writes, we did look at predictive performance of EF across the whole range of ejection fraction and found that it was only a poor to moderate predictor of events. Dagras also explained by email why these findings of poor performance did not replicate previous studies using risk scores and also CMR. He posited that things change when you try to apply prediction from small studies to such large studies as he had. In general, it was a sobering analysis and yet another example of how hard prediction can be. I still believe that the PROFIT trial of primary prevention ICD versus non-ICD and ischemic cardiomyopathy is one of the bravest and most important trials of a generation, and I'm glad it's being done, and I look forward to its results. All right, next topic is plaque imaging. Speaking of risk prediction, Jack has published an observational study looking at the matter of predicting death based on subclinical atherosclerosis detected by ultrasound of the carotid artery or use of coronary artery calcification. Dr. Fuster himself is the first author, and this study took about 5,700 asymptomatic U.S. adults about age 68 to 70 who were part of the bioimage study. This was enrolled in 2007 and 2008. Slightly more than 10% of their cohort had a follow-up carotid ultrasound. They then followed these individuals for 12 years, which is a long follow-up, and they correlated measures of subclinical atherosclerosis with mortality. Their hazard ratios were 1.23, so 23% higher risk for carotid plaque burden, and 1.15 or 15% for coronary artery calcification. Now, there was lots of overlap, even though the point estimate for the carotid plaque burden was higher. They found that the presence of carotid plaque burden and coronary artery calcium increased the risk of death. They also found a graded higher risk in the small cohort who had repeat carotid imaging and who had progressed. Medscape Medical News quoted Dr. Fuster as saying, quote, "It's going to change things." Quote, "What I believe is going to happen is that we will begin to evaluate people with risk factors at age 30 using imaging. Today, we evaluate people at age 50 using clinical practice guidelines." The editorialist for this paper wrote, quote, "The presence of atherosclerosis is powerful knowledge to guide the intensity of therapy and to motivate patients and clinicians to treat it." Okay, my comments. The authors and editorialists are obviously enthusiastic, but I am less convinced. First of all, I want to push back on the notion of scaring the patient with images. The idea of using an image to scare a patient into improving lifestyle is unproven. I can cite studies showing that it makes no difference, and few things in medicine bother me more than using fear to coerce patients. Second, while they show us a hazard ratio implying that carotid imaging is better than coronary artery calcium scores, the 95% confidence intervals overlap quite a bit, and declaring superiority of one model over another I think is suspect. While I am no fan of CAC imaging, certainly not of a near 70-year-old patient like those in the study, at least CAC imaging is easy and reproducible and gives a number. I expect that three-dimensional imaging of carotid arteries and carotid plaque burden is going to be a lot harder than replicating than calculating a CAC score. Third comment, I may have missed it, but I did not see how this relative risk increase translate to an absolute risk increase. I think that's critical to determine how doctors and patients think about what to do with this data. Fourth point, a colleague of mine in prevention research noted to me that this is like the 18th time something like this has been found. I don't have these references, but it should come as no surprise to anyone that more plaque and more coronary artery calcium should associate with a higher death rate. Finally, and this is actually one of my main criticisms of coronary artery calcium, can a normal person contextualize a small probabilistic increase in risk of a cardiac-related death over 10 years? What I mean is that if you're like one of these patients in the study, a 70-year-old, and you don't want to die of atherosclerosis, then of course you exercise, eat right, stay thin, you maybe take a statin. What else is there? If a doctor images your carotid and says you have plaque and this might increase your risk of death by a certain percentage, say you go from a 7% 10-year risk to a 8.5% 10-year risk, how does that help? You may have created fear. Maybe you increase statin intensity a little bit, but I just don't know if it's worth creating the fear. Dr. Fuster thinks we should do this at younger ages, but imaging is costly, and preventive things that patients can do are multiplying like crazy, like digital health and watches, etc. Someone has to pay for vascular imaging. Thus, it should be and could be subjected to randomized controlled trials. You know, trials like the Dr. Axel Didrikson did in Denmark with the Dankavas trial, which was technically negative per the New England Journal, but because the p-wave was 0.06. But I actually think this group showed that vascular screening done in a very Danish way in Denmark could work. I am skeptical that with all the things that we do to stem the rising tide of severe cardiometabolic disease, three-dimensional imaging of the carotid ranks pretty low. All right, next topic is WATCHMAN Decisions need improvement. Dr. Emily Zeitler and colleagues have published in Circ Outcomes a sobering observational study about long-term outcomes in patients who get a WATCHMAN implanted to occlude the left atrial appendage. This group sought to evaluate the rates of stroke, bleeding, and death among Medicare beneficiaries following left atrial appendage occlusion during initial commercial availability of the device overall. Now, before I start, I want to say that this is a good use of observational data. They aren't choosing two non-randomized groups and comparing outcomes. Instead, they're using Medicare data, claims data, to report on important outcomes in the years after an implant. Two more background facts. The entire purpose of left atrial appendage occlusion is to A, reduce stroke and reduce bleeding, not over months, but over years. We don't expose patients with atrial fibrillation to stroke reduction strategies such as oral anticoagulation for a week or a month. We do it for years. So even in the best of centers, procedural complications occur at some percentage with this procedure. So patients must trade an upfront risk for future risk reduction in either bleeding or stroke. So it takes years for this probabilistic risk reduction to accrue. Second point, WATCHMAN prevents strokes by only one mechanism, embolism from the left atrial appendage. But older patients with AF have multiple causes of stroke. For instance, the population attributable risk, or PAR, of AFib for stroke is probably less than 20%, meaning if you eliminated all atrial fibrillation, you'd only reduce stroke by less than 20%. So, the more competing risks of stroke and bleeding a person has, the less likely they are to gain from stopping one type of stroke, that is, left atrial appendage-related stroke. And that is, if you even believe that percutaneous left atrial appendage occlusion can actually reduce stroke, but I'm not sure it does. So anyways, that's the background information. The study had nearly 49,000 patients who had 1 year follow-up after a WATCHMAN. Now, pause there and let's just think for a second. What would happen if we had had even a fraction of these nearly 50,000 patients who were randomized in a proper trial? We would actually know something, but we don't have any trials. We just did this procedure. The average age was 77 years, CHADS FAST score 4, 42% female, and about 35% of patients in this group were older than 80 years. At 5 years, the investigators found that 44% of patients had died. By 2 years, it looked to be just under 20%, as the rate of death increased steadily by about 8 to 10% per year after the implant. Said another way, just short of 1 in 5 patients who had this device in the U.S. were dead at 2 years. At 5 years, the cumulative frequency of hemorrhagic stroke was 1%. Bleeding was most frequent in the first year, 7.3%, of which most occurred in the first 6 months after the WATCHMAN procedure, with a 5-year total of 14.7%. So, a couple facts on subgroups. Medicare beneficiaries with a prior stroke who underwent WATCHMAN differed from those without prior stroke in several ways. In particular, patients with prior stroke were frailer and were more likely to have serious comorbidities, including congestive heart failure and diabetes. At 5 years of follow-up after WATCHMAN implantation, patients with prior ischemic stroke versus no ischemic stroke had higher rates of death, 48% versus 44%, and they had higher rates of ischemic stroke, 12% versus 6%, and higher rates of major bleeding, 19% versus 14%. Similarly, when compared with those without a prior major bleeding event, WATCHMAN recipients with a prior major bleeding event were also older, frailer, and more likely to have important comorbidities, including prior stroke. And over the 5-year follow-up period, patients with prior bleeding versus no prior bleeding were also more likely to die, 49% versus 41%, and they had higher rates of ischemic stroke, 8 versus 6%, and major bleeding, 22% versus 10%, compared to those without prior major bleeding events. So my comments: this is important work. While I wish we enrolled higher-risk patients in regulatory trials, the reality is that regulatory trials are done in relatively healthy patients under the watchful eye of trial coordinators and experienced operators. In other words, a best-case scenario. Once approved, however, the device then gets used in less ideal patients with less experienced operators. So studies like this that describe what is happening are very important. The first take-home I take from this is that patients in the U.S. who get WATCHMAN are older and sicker than those who were in the regulatory trials, which were not conclusively positive, by the way. Remember, protect and prevail. But being older and sicker does not necessarily equate to the fact that WATCHMAN would be less effective, though it's highly likely that it would be less effective, primarily due to competing causes of stroke and death, as well as a higher procedural complication rates. Of course, the way to know whether it would be beneficial in these higher risk patients is to do a proper RCT, which isn't done. The second take-home I take from this study is that the mortality rate in these patients who have WATCHMAN is very high. Nearly half were dead by 5 years. This is nearly double that in the long-term follow-up of patients enrolled in the continued access registries, and there it was about only 20% at 5 years. And I'll offer you this quote from the authors. Quote, "Of note," they write, "the 5-year mortality rate in the Medicare population far exceeds the 5-year rates of stroke and major bleeding, which are like those seen in clinical trials. These findings highlight the high competing risks of death in this older and highly comorbid Medicare population," end quote. Now, one little area of pushback. The authors discuss ischemic stroke rates in this post-WATCHMAN population, noting that it's only 1.4% per year and similar to what we would expect in warfarin treatment. But it's less than what would be predicted without any treatment based on the CHA2DS2-VASc score alone, a median of 4, which would estimate an annual stroke risk of 4.8%. While I love this paper, I don't love the fact that they made these historical comparisons. I think that historical comparisons are really fraught. For one, we don't really know what the annual stroke risk is in certain CHA2DS2-VASc scores. Yet, these are the types of observational studies that I do like. Remember the quote from the surgeon Joseph Bavaria, who likes to say, "Science tells us what we can do, trials tell us what we should do, but registries like this show what we are actually doing." I will close by saying that stroke has many causes. The proportion related to left atrial appendage traumas likely declines as competing causes of stroke go up. When I lost my first WATCHMAN debate to Professor Horst Sievert from Germany at the ESC meeting many years ago, he said in the Q&A that the patients least likely to benefit from the WATCHMAN procedure are older and frailer patients. This study tells us that these patients frequently get the procedure in the United States, and many have high death rates afterwards. And I would say that if you die soon after having a WATCHMAN, the only beneficiaries are the company, the doctor, and the hospital. I say good on the researchers for this important paper. Last topic today is deprescribing. Now, patients who are doing well often ask me why they should keep coming to see me every year. My answer is that one of the most important roles of follow-up clinic visits in patients is to assess the value of medicines and to stop these medicines if it's no longer beneficial. Now, medical people give this common sense practice the fancy name of deprescribing. In fact, one of the dumbest things I see in clinic is when I see a 90-year-old who has a systolic blood pressure of 110 but is on 3 blood pressure-lowering drugs. I mean, this is even dumber than a 90-year-old on a statin. JAMA Internal Medicine recently published an observational study from a UCSF team that sought to find causal effects from stopping antihypertensive meds in older adults who were in long-term care. Their basic question was, did deprescribing of blood pressure-lowering medicines improve cognitive function? Now, I've said this before, but it is worth saying again. The entire purpose of preventive medicine, like blood pressure-lowering medicines, is to become elderly. Once elderly, the previously beneficial medicines may not be beneficial anymore. Aging changes things. For one, drug clearance is reduced. The same dose of the medicine may lead to higher steady-state blood levels and toxicity. For another, aging means taking more medicine, which makes the drug-drug interactions more likely. Finally, aging changes your physiology. Blood pressure may simply not be as high as it once was when you were in your 50s or 60s. Older patients have, in one sense, achieved success. Our job is not to create a headwind for this success to continue. The UCSF team studied older adults, mean age 77 years, who were in a VA long-term care facility. They started with a sample size of more than 45,000 adults, but they excluded those with significant high blood pressure or heart failure and other various good reasons to remain on the blood pressure meds, and they ended up with 12,000 study subjects. About 1,000 of these 12,000 had their blood pressure medicine stopped. These were the treatment arm. Nearly 11,000 did not have their blood pressure medicine stopped. These were the control arm. Now pause and note here that these were quite uneven group, 1,000 versus 11,000, and clinicians, not randomization, chose to stop or not stop the meds. In addition, I'll add this quote from the paper, quote, residents in the control group had higher baseline blood pressure, lower median activity of daily living scores, and they were taking fewer antihypertensive medicines compared to the deprescribing group, so baseline differences. The authors then measured cognitive function after 2 years using a 4-level scale, 1 intact, 2 mildly impaired, 3 moderately impaired, and 4 severely impaired. Now, the authors knew that the groups were not randomized nor similar at baseline, so they made adjustments. They even gave these adjustments the name, quote, target trial emulation, which, as it sounds, is a way to mimic what a randomized controlled trial would do. I'll come back to this in my comments. The main result of this paper was that it was positive. 10.8% of the residents in the deprescribing group versus 12.1% in the stable user group had a worsened cognitive function score. In analysis looking only at those who remained in their category, deprescribed or continued, those in the deprescribed group had a 16% lowered risk of cognitive function worsening over a 12-week period, which reached statistical significance. The authors concluded that this was novel evidence regarding the association of deprescribing blood pressure-lowering meds. They wrote that the residents who were deprescribed these meds had slower cognitive decline compared to those who had medicines continued. Okay, my comments. The first thing to say is that it's great to study older adults. This is an opinion, but I don't think we do very well in the care of older people. I think this mainly because we use the wrong frame, right? We apply STEMI-like care to older adults. I call it the fix-it frame instead of the get-out-of-the-way-of-success frame. Perhaps that is why we resist stopping preventive medicines like blood pressure medicines or statins in older, frailer adults. So at its core, the UCSF team attempted to persuade caregivers to deprescribe preventive medicines with empirical data. And evidence, I think, is a good thing, but persuasion with data requires extreme care. I write this because you lose trust when the evidence doesn't pass muster. We saw this phenomenon during the pandemic. Authorities would propose policy A or B or C, but the supporting evidence was terrible or non-existent. And I think the end result was loss of trust. And I think this study falls short of its goal, which I believe was to find causation. First, this is a retrospective look back at two non-random groups. Adults who had their meds continued, the control arm, were sicker than those who had their meds stopped. The authors made statistical adjustments and even set out a specific time to start looking, but ultimately there was surely confounding. They called this a target trial emulation, but I am not sure it is just a typical observational comparison study of two non-randomized groups. Second point to make is that confounding occurs because you can only adjust for factors in the medical record, and clinicians make decisions like deprescribing based on many factors. And here, to the author's credit, they offer a measure of confounding called the E-score. And in this case, their E-score indicates a substantial chance that differences in the groups drove the cognitive score differences, not so much the deprescribing. And another problem with this study is the primary outcome. Cognition is a tough thing to measure, and it was barely different, right? The main results differed by less than 2 percentage points. That doesn't seem like a lot to me. Plus, when you go into the supplement and look at E-figure 7, there were only tiny differences in the mean blood pressure changes in the two groups. It's therefore seemingly implausible, to me at least, to suggest that a few millimeter differences in blood pressure would drive an improvement in cognition. More likely, the difference that they found was due to the bias of baseline differences in the two groups. In summary, in many cases where meds have caused harm, deprescribing in older adults approaches such a high level of common sense and empathy that evidence is not needed. In situations where we aren't sure and you want to use evidence, it should be stronger than confounded observational studies. To me, this is a classic case for using trials, even the non-inferiority randomized trials. Then you measure something more obvious, such as mortality, hospital readmission, or weight loss. I would conclude by saying that weak evidence does more to hurt a cause than support it. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time, give us a rating, write us a review. These things go a long way to help others find us. Also, thank you for the comments. I'm learning a ton from them. If you disagree with something, please feel free to write a comment on the heart.org website or contact me by email or even on Twitter. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.